Okay, well, this is Amy Lujan, and this is the Juneau Gastineau Rotary Club session, and this is on October 20th. And we are pleased to welcome today our guest, Dr. Zink, who is the state's chief medical officer. And I'm sure lots of you have read her name in the paper and perhaps watched some of the regular sessions that she's been doing to update us on the pandemic. So we're very pleased to have her today. Her time is a bit limited, so we wanted to get right into her presentation. So thank you for being with us, Dr. Zink, and I'll turn it over to you.
Great, Amy. And I don't know if I can do screen share, and I'd love to screen. If not, I'm happy to do it otherwise. But first of all, thank you all for being on here. I think one of my favorite things is going on these Zooms, and it's not nearly as good as being in person, but being able to see each of you in your places. How I loved your introduction this morning, and I think that's exactly in those words this morning. We've been thinking and talking a lot about the state. I'm the chief medical officer for the state. I am a practicing emergency medicine physician who got into this job simply because I wanted to make the care for my patients better in the emergency department every day. I saw patients who couldn't get the medicines that they needed. I saw patients who didn't have a home to live in, people struggling with opioid addiction, people who couldn't pay for their knee replacement or their fractured leg because of the way that our healthcare system is set up. And so as a result, started to get more involved in kind of policy and what was happening across our state. And I've always felt like Alaska has this unique ability to really kind of lead the way in healthcare in many ways. We live in this beautiful, diverse, incredible state where we have to ask questions. Does it really make sense to send that person to the big specialized unit? What can we do rurally? What can we do locally? How can we use specialized care from across the country? And how can we really work collectively? And I think one of the things that really inspired me to just continue working here and becoming more involved has been the involvement of the public in healthcare and the ways that we as a community can take care of each other and how much that does to keep people healthy and active and how much that actually impacts people's health. Everything from the way that we structure our communities and our towns, the ways that we support each other, just, listening to you all this morning, greeting each other and those who are with you as well, and the importance of community. And it's one of the things I just absolutely love about Alaska. I've been up here for 13 years and can't imagine a different place at this point. Back last July, I got asked by Dr. Jay Butler, who's the previous CMO, who some people know, if I would be willing to consider this job as he moved to the CDC. And it has been a journey that I never really expected, to say the least. I really love practicing clinical medicine, and that's what I got into this job too. I'm fortunate that I still get to do it. And then, as you all know, come December, we started to hear rumors that there was, a fairly large virus outbreak in China, and wasn't exactly sure. I still remember to this day having brunch with Dr. Butler after he had just climbed a peak while he was in town. And he was getting calls from China trying to describe what was happening. And I remember him saying, this could be big. I think we need to be prepared for this. And that was kind of the start of a very long 8 months at this point now. In January, then we were notified about the Wuhan flight that needed repatriation. And that's when we stood up our emergency operations center. And it's basically been full on every day since that point forward, trying to learn about this new virus that we knew nothing about, to being able to try to keep it off of a US soil, trying to keep it out of Alaska, and now every single day trying to keep it out of communities and making sure that people stay healthy and well and have the tools and resources they need. It's fascinating to me how much we've learned in an incredibly short period of time about this virus. We are all citizen scientists in many ways now. I'm sure many of you could tell me about R-naught values and about all sorts of treatment options that you never knew about a year ago. And it's been a really fun process to watch communities just become very involved in this. And I would have to say it's been particularly fascinating to watch many of the Southeast communities in Juneau. I think you guys have been, I don't know how many city councils in Juneau I've been involved with now, but you guys have been actively engaged from the beginning, and it's been great to see people learning and us trying to respond to both the virus as well as the fantastic questions. So what I was going to do, oh, perfect. Thank you, Amy. I so appreciate it. I'm going to switch over, and this is just the data dashboard. Can you see this okay? Yep, great. Thanks, Doug. So I switched all the metrics to Juneau. And so you can switch over here to any sort of region that you specifically want to take a look at. And we try to get this data as accurate and transparent in real time as we can. Most of this data has to be reported to us from the actual area that's doing it. So to get like these test results back, if a location in Juneau does the test, gets a positive, then they report it to us, and then we enter it into a system we cross-reference it to make sure that we don't already have that person, and then we enter it. So oftentimes our data is a little bit delayed compared to what a local EOC or community would have. And that would be expected, and we really appreciate the local EOC standing into that space. So here I collected Juneau, and you can see the number of cases in Juneau. I can click and do multiple boroughs or cities. I can click in-state, so if I just want to see how many in-state residents have had it, I can click at how many Juneau residents got it out of the state, so that would be 2. I can collect and see all resident and non-resident cases. There we go. And you're going to get 224 versus if I just click resident cases, I'm going to get 148. So you can play around with this data quite a bit, and there's a lot underneath here. New cases every day are going to be listed here. This gets listed about noon every day. I haven't seen the email come out this morning. You can see total hospitalizations in any given region and total deaths, and you can see the number of cases. You can also see things like the acquisition of disease, how someone got it. If it was a secondary case, meaning oftentimes it's a family member, although it can also be a work colleague or some close contact. Communities, when we have a hard time identifying exactly where it came from. Unfortunately, there's a lot of this gray that's under investigation, and our team really turned and pivoted to contact tracing when the cases really started to pick up. And so the data entry part has been lagging. So we have now hired a whole team of data entry people to try to kind of go back and pick up through this data. And I'm really hoping in the next couple of weeks, this really becomes cleared out and we're able to see quite a bit more data sooner. This does take a bit just as we're interviewing people. If I go down further, I can then see the testing dashboard. And again, I switch this to the Juneau area. And you can see your % positivity over time. And this is a really good indicator if your community is doing enough testing. So WHO says you should keep it under 5%. One of the Harvard studies says it should be under 2%. Most people agree it should be under 10%. So we've kind of classified less than 2, 2 to 5, and greater than 5 are the metrics that we use in the state for thinking if there's adequate testing to just make sure that we're testing adequately. And Juneau, as of this morning, is 0.86% testing. So that's great to see that number. And you can layer that over another area. So you can layer that over, say, Anchorage, and see what that looks like overall for % positivity. You can also see things like the turnaround time. And so again, if I'll just take Anchorage off. The state turnaround time for Juneau is 3.7 days. Facility is 0.7 days, and commercial lab is 2.8 days. And so this really speaks to the distance from the state lab as well as the commercial lab versus really quick facility lab turnaround time here. If I switch that to, let's say, all available, you're going to notice that the facility lab goes up significantly. So most people don't have the same sort of facility turnaround time that Juneau is having, but slightly better state lab turnaround and about the same commercial turnaround time. So you can see what that looks like. And these are ways for us to kind of track and trend how much data and what the turnaround time is in different regions. You can see what sort of testing area is in your location. And then the other graphs that I really like, and this one had a glitch last night. So hopefully it is all up and working this morning, and it just takes a minute to load. This is the projection modeling, and we're going to be doing another one for healthcare capacity here soon. And you'll be able to see this kind of projected epidemic curve, the reproductive number. Here we go. Now it's loading. My camera never really loves to do Zoom and this dashboard at the same time because they use a lot of data. So this is the projected curve, and if people have been following this, you'll see it changes a tremendous amount. Modeling is really hard in the state of Alaska. We're so big with so few people. Every modeler I've spoken to internationally and nationally says, don't use my model in your state, it's not gonna work. And I'm like, well, it's not really helpful. I need a model. I need to have a better sense of like what these numbers will look like. And basically they just say, good luck. Most of the national models just really don't apply here. Our team has built these models based on a lot of the national models to try to give most accurate representation. And they are also finalizing just a really detailed kind of hospital capacity model as well. My guess is that when we see it active and live, it's going to be similar to these, that you'll just see the immense variability that can happen when we have an outbreak in an area, how much that can change the modeling and prediction, and why all of these things just need to be taken with a grain of salt. So here you can see kind of that first wave, or wavelet, as our team has been describing it. And we had the big outbreak in the transitional care facility in Anchorage, and that kind of started the second wave. And then that outbreak kind of resolved, but then many people kind of contacted and got COVID in different ways, and really got settled in many rural areas around the state. And then we had a series of outbreaks right around this time, particularly 4 large fishing outbreaks and a couple outbreaks in your guys' area that have been kind of driving these most recent numbers. And now, in general, we've been kind of seeing a decline / flattening, and you can see the estimated having time of 41 days. The other data site that I like a lot is this average daily rate. And so there's a lot of news and media out there about what numbers to look for. We put our rates at number of new cases per 100,000 per day. Other states do it differently. So Washington State, for their school opening, has number of new cases collectively over 14 days per 100,000. So if we had one case a day for 14 days, we would count that as one case per day per 100,000 people. They would count that as 14 cases total over 100,000 people in 14 days. So it's important when you're looking at other states and how they're opening schools or what they're doing that you make sure you're comparing apples to apples. Some are 10,000, some are per 100,000, some are per 1,000,000. Some states are really using percent positivity because testing is so limited that they're using that as a marker of what should kind of open or not open. We've spent a lot of time looking at this, and not to say that any one tool is perfect, because no one tool is perfect, and why we want to make sure all these tools are up here. But over a 14-day period works better for a small population area. And giving the number of cases per day, we and a couple other major groups chose this number because you could better compare it to what you see on a daily basis. So if you hear that we had 14 cases today, you get a better sense of like, oh, that's in that reddish zone because that's more than 10 cases per 100,000. And so if you have a better sense of what's kind of happening there. There's no good number. The federal government has not told us this is the number we should be using. It would be nice to all be able to compare apples to apples with each other, but we just don't have that yet. So this is what we've been using. Most epidemiologists will agree that if you can keep your number less than 5 new cases per day per 100,000, that just basic testing, tracking, contact tracing is what you need to be able to keep this from getting into an exponential curve, from overwhelming your hospital system, and from really impacting your community as a large. So if we can keep it in that yellow range, that's really, really helpful. When we get into an exponential climb, and when we get into this red region, that's when mitigation techniques are more needed. That's when you need many more people kind of stepping up, really pulling back socially, making a difference in keeping those groups apart, potentially not having groups clustered either by legislation and or by mandates, really having people wear masks absolutely all the time. So again, the mitigation efforts need to fit kind of the amount of community cases that you have. And so we try to kind of put this out there and show what's happening across the state so that people can know. So here's Alaska as a whole. And again, this is all information that we've been learning in a short period of time. And this has come down here now into the orange region. I would say that we probably have more cases that we're picking up than many other states, simply because we are testing so much more. We are the most tested state in the nation, and we test more per capita. That being said, we're definitely not picking up all the cases. And so how many quote are we missing? It can be really hard to say. There's estimates from different literature that you would miss anywhere from 6 to 24% of the cases. In looking at our percent positivity as well as our rates, it's estimated that we're missing somewhere between 5 to 10% of our cases in the state at any given time. So just to kind of give you a sense of where we're at, but probably not near that 24%. That states would be if they were having, say, a positivity rate of 15%. That's when you know you're missing a lot of cases versus our positivity rates been hovering around 2% overall. I can then click this and I can click the behavioral health region, and then I can click the Juneau region, and I can see, so kind of right along this yellow, and then recently with this kind of spike into the orange and the red. I'll just also point out these large gray bars. Again, when I mentioned that the modeling is always limited, the smaller the population, the more the modeling is hard. There's a great quote by an epidemiologist who says that no model is perfect, just some are useful and some aren't. And so these are what we call confidence intervals, and these are just very large confidence intervals, meaning that when you get a small population, it becomes really hard to kind of give estimates. And so you can see you get much larger confidence intervals when you get to a place like Juneau. The same happens with the reproductive number, which I think many people learned lots about initially on. And the reproductive number is if I have the virus, how many people would naturally get it just in their normal mixing. And in general, we still think that this reproductive number is about 2.5. To give you an estimate, the flu is about 1.2, measles is about 15. So you can see a big range in diseases based on kind of how contagious it is. What we do as individuals and humans affects this number. So if we wear masks, if we stay 6 feet apart, if we're washing our hands, if we're really making sure people who are sick or infected or close contacts are quarantining for 14 days, that directly impacts that number, and that makes it so it can't spread to as many people. So naturally, it's about probably 2.5. You can see statewide at our worst, when it was spreading with a couple big outbreaks, we got up to 1.82. And you can see it has come down to 0.87, or actually it's 0.95 right now with a lower confidence interval of 0.87. So it's been great to see it go below. And the reason there's this dotted line at 1 is because if it stays under 1, that means that one person gets sick. In general, they're spreading it to less than one person, and this pandemic and epidemic goes away. And so we always want it like below 1, because then it's going down. It's also important to know that this number can really vary, because if you have, 4 people who have it and they give it to 16 people, well, that's not that many people. The R naught is quite large. Versus if I have 100 people and they give it to 105 people, that's not a very large R naught value. It's just still a lot of people who have COVID. So it's, again, one tool in a larger set of tools that we have to use. And again, you can then click and look at Juneau specific and see. And you can see that when you get to a smaller population, your confidence intervals get much larger. You get a lot more kind of bouncing around associated. And that's why these tools aren't as useful kind of for smaller communities as a whole. But we just, again, want to make sure we get asked this question all the time. And you can also add to these resident and non-resident if you want to see what that looks like, both for Juneau and for statewide. So with that, I'm just going to pause and just say a couple different things. First of all, if you look at the deed school opening, there's no set guideline that the state has said at this level you open, at this level you close. What we said is here's a bunch of tools and you know your community and we're here to help you. DHSS does not approve of any of the school plans, and we are just here to support schools in making these decisions. And it's impressive to see how much time and effort superintendents and teachers and school districts are spending trying to figure this out right now. They too are epidemiologists and protectors of the kids and community and teachers, and trying to find ways forward through a really, really challenging time. We have school echoes for teachers. We have an entire team to support schools, including Dr. Liz Olson, who's a primary care doctor, who meets with them and reviews all the plans and gives direct feedback. So that's another question I get asked all the time. And then just a couple last little kind of points I always want to clarify. First of all, each case is an individual case. They're not repeated cases. So if someone tests positive multiple times, those get then reconciled and just counted as one individual person. The tests, however, are the total tests done. So that may be multiple people, or one person might have multiple tests that show up as the test done. So that question comes up. Another question that comes up all the time is false positives. In general, these tests that are being used, which are called PCR tests, almost all these are PCR tests. A couple of them are Abbott Now test, which is a molecular-based test, have a very low false positivity rate. And so really think that every test that's a positive is really a true positive. The questions we get, well, where so-and-so was asymptomatic or they didn't have any symptoms, therefore I'm sure it was a false positive, or they had another test a week later or a couple days later that was negative and they were fine, it must be. I think what's really hard about this disease is how incredibly asymptomatic people can be. And so estimates anywhere from 20 to 40% of people will be completely asymptomatic with the disease, yet they can shed it and share it with others. Our data showed that 81% of people had symptoms at some point. They may not have gotten tested because they had symptoms. They may have gotten travel testing or pre-procedural testing and then developed symptoms afterwards. But you're actually just as contagious, if not slightly more contagious, prior to developing symptoms. And that is what makes this disease impossible to try to figure out how to keep it at bay. The flu, when you're most contagious, you feel most awful. And so it's really easy to know to stay in the house. But this disease, you don't know that you're spreading it to others. And that's what makes it really hard to stay in the house when you're not feeling well, to wear a mask when you're not feeling well. You still shouldn't go out if you don't feel well. Don't get me wrong there. But that's part of the reason why we're asking people who are otherwise healthy and feel fine to still stay apart and wear a mask, is because you may not know that you're spreading the disease to others. These tests have a fairly high false negative rate, meaning they don't catch enough virus or the virus breaks apart as it's in transport or as it's in the running the machine. And so if someone otherwise feels well and they had a positive test and then the next day they had a negative test, it's much more likely that was the false negative than truly a false positive. And that's why we really think that most positives are true positives. There are exceptions, and there are no test is perfect. And so every test where this may come up, we do an investigation and try to figure out if there's any chance there was a false positive or some error in the process. But I just wanted to kind of put that out there as well, because that's another question I get all the time. So with that, I really appreciate everyone's morning. I love seeing everyone drinking coffee with me this morning as we're all kind of getting started. And I'd love to answer any questions, be of any assistance to the community.
Amy, this is Doug Eklund. Has the state done any antibody tests?
Yeah, so great question. So antibody tests need to be reported to us. And so many communities are doing antibody testing and reporting them to us. We also are using antibody testing as part of some case investigations. And so when we're trying to understand better an outbreak of what's happening, we will use antibody tests in that realm as well. The problem is the antibodies look like they probably go away on most of the tests somewhere between 2 to 3 months after someone gets the disease. So it's only a short limited period of time. We don't have good evidence on how well the antibodies protect you. So if you had positive antibodies, I couldn't necessarily say you're protected for even 2 months. Don't worry about a mask, go out and do your business. That was really the hope when this disease first started, that we'd be able to test people for antibodies and you'd almost get this golden ticket. So it doesn't help us that way. And as a result, it's kind of just an interesting information piece and or a piece to help us with investigation outbreaks, but not a really good population tool. It's not coming out to be as useful as we were hoping from a population standpoint. And so that's why we aren't spending lots of time and money trying to antibody test a lot of people, but we are looking at the antibody tests that are coming in, and we are using them in case investigations to make sure that we're getting everyone associated with that cluster.
This is Amy. I was just wondering if there's any other sort of positive news on the testing front going forward. It seems like anecdotally, I've heard that people have waited a lot longer for test results in many cases, and it just seems like this whole thing could be improved to help us give more information.
I am totally with you. I mean, I reflect regularly on the fact that we are the most tested state in the nation and how hard it is here and how long it still takes to come back and how broken it still is and how much longer we still have to go. There is a ton of news on the testing front, which is exciting to see. So one, we got more Cepheid reagents, which we have been issuing out, including to Juneau, to be able to increase some of the turnaround time there. So that's good. Antigen test is the big new question out there. There are now, actually last night, FDA approved a third antigen test. There's 2 previous antigen tests. Antigen tests are kind of like when you go to the doctor and have a rapid flu. It's not a perfect test, but it's a really quick, cheap, easy test that you can use in combination with other tests. And a couple of centers now in the state have antigen testing. They probably miss maybe about 20% of cases. But more and more looking at it, it likely misses kind of what we call the ends of the cases, when people are least infectious, but really pick up when people are most infectious. And so if you could use a cheap antigen test on a really regular basis that comes back quickly, that's going to probably be more sensitive and more accurate overall than it would be a really expensive, very complex PCR testing. So some of these antigen tests look like they may come down to like $1.50 a piece. I mean, if they come down to that price, that is a game changer compared to $120, $150 a piece. And you could theoretically have schools, have kids do a little, saliva test before they head to school every single day, cheaper than probably most of them are going to need to get PCR tested during the whole school year a couple times. So there is a lot of excitement in that front. There isn't much approved yet. Admiral Jawad is the kind of guru of testing in the nation. We do talk to him on a regular basis. They have invested a significant amount of money in antigen testing coming forward, and we are told to hope by the end of September to have a lot more antigen testing up and around. Thinking about places like Juneau and legislators coming in and out and what ways we can use antigen testing in that realm. I am really hoping for more front. The other super exciting front is both antibody delivered medication. So instead of just a vaccine, that you could get what's called a monoclonal antibody, a manufactured antibody, not just plasma. And there's a lot of good news on that front. And then vaccines, there's a whole, we've always had a team on vaccines, but we have expanded that team out. There's up to right now 7 vaccines that they're telling us to be prepared for that include different cold chain storages, different timing, and different populations who would need it. To be able to think about what that looks like. But we basically are prepared for beginning of October to be actually making sure we're figuring out how the system goes forward, so that by November, December, if any vaccine is ready to go, particularly for high risk populations, we would be able, the moment it got here, we could get it to people right away. So there's a lot of excitement on that as well. So those are the 3 worlds we're watching really closely right now: antigen, treatment, and vaccine front.
One of the things I just heard about last night, and this has to do with travel, some family members from the East Coast were here, and in order to get tested, in order to come into Alaska, they found someplace online where they could order the test, self-administer it, and then send it off to the lab. And they had their results in 2.5 or 3 days. I had never heard of that before, but I thought that was interesting for people who need to travel.
Rosemary, I really appreciate you bringing up that point. Yes, there are 4 at-home testing sites. They are up on our website and you can take a look at them. Anyone can order them. You can use them for travel or non-travel. We are encouraging, clinics who want to do pre-procedural testing, people who want to travel. You may want to have a couple in your house because if you're not feeling well, you could just do it then, and then you can send it in yourself. They are sometimes cheaper than going to another center to get tested. Insurance covers most of them. We've worked very closely with them to make sure that they do cover all of our mandates as well as travel and pre-procedural in the state. And there's 4 companies online. The biggest thing is you have to have access to shipping to ship it in. But we are seeing 12 to 48 hour turnaround times for those currently right now. So we are seeing pretty good turnaround times. And if you travel, you can just throw it in your bag and do it yourself, send it in, and then you get emailed the results back.
Right. These people were from Ohio, so it worked out really well for them and far less expensive than paying $250 in the Juneau airport.
Yep.
Yeah.
Who determines what type of vaccine you're going to get, seeing as how you're going to have a large number of vaccines available?
The science will determine which vaccine. So there's probably some vaccines that are going to work better for like young healthcare workers. There's going to be other ones that are probably going to be better for people who are older. We're just going to have to see how many come out and what the science and data looks behind them and what the safety profiles look and the efficacy profiles. So we already know that from previous vaccines. So like for flu vaccine, people who are over 60 don't make antibodies really well to the flu vaccine. So we have to give a higher dose vaccine. So we have a separate vaccine for people who are older, and likely the same thing's going to be with COVID. It's really going to be the data and science to say this one would make more sense for this component. Likely what will then happen is the CDC will say, okay, based on this vaccine, here's the high priority group that initially gets it, and then this group, and then this group, and then they give it to the state and or they directly ship it to then be able to administer it out from that point. Does that answer your question, John?
Yes, thank you.
Dr. Zink? Can I ask a question?
Yeah.
So I was up in Anchorage. A friend of mine had to have emergency heart surgery. I was up there helping them. And they have a 15-minute COVID test. You go in, take the test, sit in your car, and the results are delivered in 15 minutes. Is there a reason why that's not made more available?
Yeah, so that's the Abbott Now test. And there are Abbott Now test machines and cartridges in Juneau. It's just supply and demand. We do ship out the Abbott Now cartridges if we ever get them from the federal government. People can order them. Companies and cities can order them. I would say that we've gone from we had a bunch to absolutely none for months. The White House just had told us on Monday that there are more available. So now everyone's scrambling to order more Abbott Now testing available. Some states don't use the test at all. There was a study that came out early that showed that maybe they weren't super sensitive. But when you looked and read the study carefully, people were putting the swab into a medium and then putting it into the analyzing machine. And that process made it fall apart. And so the machine wasn't super sensitive. We've done our own internal validation on the Abbott Now and find it just about as good, if not as good as the PCR testing. And so we've been using it consistently. We use more Abbott Now than any other state because they're those very quick, rapid. They're small too, they're like a little box. And so we've been able to put them on fishing vessels. We've been able to use them. We have a mobile strike team that we use when there's a big outbreak in a certain area. We can send a mobile team with a series of those machines out there. Almost all of those machines have been purchased by, hospitals, clinics, or other people to have them. Some long-term care facilities have purchased them as well. We try to advocate on a federal level to get as much as we possibly can in the state, such that you have rapid kind of point-of-care testing because of the length of time it takes to travel. But there are Abbott Nows in Juneau, and it's just a matter of getting more as well as continuing to have access to them and continuing to get more. The Cefiad is a 45-minute test, and they can do either 4 or 10 at a time. Some can do 16 at a time. I would also say the one limitation on them, it's kind of like a coffee in a Keurig cup versus a large production. Like they're one at a time and they're very manual intensive. And so they work really well for like the one person who's not feeling well right at that moment to get tested and wait for the 15 minutes. They don't work well when you have to do an outbreak investigation of 150 people or a bunch of people flying in. It would just take hours upon hours. We had a seafood vessel and they had the Cefiad, which is again a little bit faster than the Abbott now because you can do more at a time. And the clinic in Dutch Harbor basically just stayed up all day and all night running individually these little machines because it's just these little tiny ones. So there are some limitations to them, but those are the Abbott nows that you saw.
Thank you.
Dr. Zink, I had a question about this upcoming twindemic, which I understand is on the way. I'm wondering if your office is working on plans for some kind of wide distribution of the flu vaccine, perhaps drive-in clinics and whatnot, because not everybody gets the flu vaccine, especially if we have to go to a little room at the Fred Meyer's, whatever.
You are totally right. We have ordered a whole bunch more flu vaccine. Some flu vaccine is already in. So some of the Walgreens and Fred Meyer's and stuff have it as of right now. Antibodies to flu do decrease over time. So in general, we recommend kind of October time to being able to get the flu vaccine. So it is there now, and we are definitely not going to discourage anyone now, but we're going to start our push to get people to use them a little bit later to try to keep those antibodies lasting longer for people. We are trying to use every mechanism that we have to increase the flu vaccine. So if that is, drive-through testing sites also offering vaccine, if that is clinics offering it because you already have that relationship, many of the pharmacies have moved to being more in Anchorage than in Juneau, but have moved to doing testing outside. And so they could easily then also add vaccine to it as well. And different communities are having different kind of campaigns and missions to be able to move that direction. There is some testing that's coming out that could test for both COVID and flu, which would be very helpful. And so hoping to see some more progress on that front for the testing aspect as well. You can get COVID and flu at the same time. We don't know if it makes it worse or better, but it doesn't sound good as a combination. We did see that at the end of the year. And then that just adds to beds and it just adds to how much capacity in general. I would also just caution people that many of the beds, I don't know Juneau's numbers on this, have been full with traumas recently. Everyone is tired of quarantine and everyone's tired of COVID. And so they're out running their ATVs and boating and not wearing their life jacket or falling off without the helmet. So still make sure that you're taking care of your physical self. Like not only should we be controlling our sugars, eating well, exercising, but doing it safely because I would hate to see someone in the hospital for another accident because they're so sick of quarantine. So all of these things, it's like a big whack-a-mole game. They all have their impacts in different areas, and making sure we're taking care of our health and wellness is important. Flu and non-flu, accident and non-accident.
Dr. Zink, you mentioned some of the contact tracing efforts that are underway, and I wonder how Alaska is doing overall in its capacity to keep doing that. I believe in other states it's just gotten so out of control and the capacity has been lost to do contact tracing. So how are we doing?
Yeah, thanks for asking a question. It's we're doing okay. It feels a little bit like running in front of a large wave at all times. The wave has settled down a little bit, which has been very helpful. We never gave up on contact tracing. So it was like, this isn't going to happen. There were moments where some of our team wanted to give up on contact tracing, and it was and we were getting behind. We were getting 2 to 3 days behind. There was one point where Anchorage had almost 300 cases where they hadn't been able to contact trace. Part of it is that we've had to kind of build this ship as we're flying it at the same time. So most of our contact tracing that had been done prior to this was based on phone calls and faxes and an Excel spreadsheet. And so since this pandemic, we've had to completely install a completely new IT system, well, 3 IT systems in the lab and 1 for contact tracing, and then try to link in processes that were normally separate. So like for Anchorage normally did its own contact tracing and was not connected to the state at all. So we had to build this IT system, connect them in, and now we have a centralized contact tracing system so that we're able to use people from around the state to help support anyone that's an outbreak. It still gets first assigned to whoever like that region is, so people will do their own region. But if we need more help in Bethel and Anchorage has more space or Juneau has more space in contact tracing, they are all now on the same system and they can help each other out. And so really in the last 2 weeks, we've gotten back to being able to contact everyone within 24 hours, which has been a huge change and not getting out to that 3 days. We used to contact every contact for 14 days, every single day for 14 days. That's just a lot of, and I don't know any other state that was doing that. And that was just a ton of time. So we've pulled back from that. So we still are asking people to contact their own contacts first as a way to speed that up. We are then kind of working through the higher risk people first to contact all of their contacts. So say they're in a long-term care facility, or they live with someone who's older, or they've got underlying medical conditions. Those are who we kind of do first. And then otherwise, young, healthy people we do next. Sometimes the contacts are really small. That's only 2 people they need to let know. And those ones are really quick and easy. Sometimes it's hundreds. And then sometimes we have to do a press release or additional information to kind of show what that looks like. And then we've been building up contact tracers over time. The UAA has been helping out. A bunch of the tribes have now contacted. And then a bunch of the FQHCs, the federally qualified health centers, are now on board as well, which has been great to have them all a part of the system and helping. And now that we have kind of this airplane built-ish, we're able to onboard people much, much more quickly. And so hoping to continue to use that in case we get another surge. So yeah, thanks for asking. That's definitely where we spend a lot of our time, but it is getting better, but never giving up.
Annie, this is Doug Eklund. How are you on time? Are you good, or
I think I'm good. I texted them. I probably got like 2 or 3 minutes.
Okay.
I'm supposed to be somewhere at 7:30, but they seem like they're hanging in there.
Any more questions?
Well, Rotarians are all about service. And is there anything we can do aside from just sort of keeping ourselves healthy, wearing masks and those types of things? Should we recruit contact tracers, or what could we do to help?
Yeah, that's a great question. Thank you. And you are about service. And I've loved going to some different Rotarian meetings across the state. First of all, I love the fact that you're meeting on Zoom and that you're taking care of yourself first. As an emergency medicine doc and as a mountaineer beforehand, we always learned that you don't want to create a second victim. So first of all, don't create a second victim, take care of each other. I think that the mental and physical well-being is going to be really important this fall. I think we're all done with COVID, and this is just frustrating at this point. My poor daughter is like, Mom, when will this end? And so I think finding ways to support each other mentally as well as physically is really, really important. I'm always amazed at how many people still don't have masks, or that is a barrier to being able to get it. So we have ordered over 1 million cloth face coverings. You can order surgical masks. Surgical masks are more effective. They're about 5 times as effective as most cloth face coverings, not all, but most cloth face coverings. And particularly those who are older, over 60 or immunocompromised, there is some evidence that they also protect you so that you are less likely to develop significant symptoms. And so working on getting surgical masks to vulnerable populations can be key. I would love to do more on contact tracing. Recruiting people can be helpful, but there's a website, and I'm happy to share it with you, on UAA. And if anyone's interested in contact tracing, there's jobs available, and we will train you and hire. And there's a whole system set up via UAA. So if people are interested and have time, great. We would love the help, and you're welcome to come join the party via that process. But the other thing is, I think about contact tracing as a team sport, and I think we need to do more about education for contact tracing. I would love to see more videos. I talked to Deed about this the other day about just think about, so if I told all of you today that you had a positive COVID test, and I told you all that today was the beginning of your symptoms, that meant 2 days ago is when you started to become infectious. If you could draw a map of everyone that you spent more than 15 minutes with within 6 feet, and then who they spent time with, you just do those. Some people's are going to be very small, but some people's are impressively large when you end up doing that. Or if I told you that, say on Monday you had been diagnosed positive because it took 4 or 5 days for your test results to come back, then you got to think back all of those days. You got to think back from 2 days before you were infectious, all the way through your infectious period, and all the people that they have tested. So I think the more education we can do on just exponential growth and how much contacts we all end up having, that can be really helpful. And then multi-generational homes, I really worry about. We are continuing to see racial and ethnicity divide and socioeconomic divide in who's affected by this. And so people who are working, stocking shelves, helping to clean houses, living in multi-generational homes, may not speak English, African-American, Polynesian, particularly Pacific Islander, and then Native American are the 3 populations that we continue to see higher hospitalization rates, higher mortality. And there's all sorts of reasons for that. Some we know, some we don't know. But finding ways to be able to get someone who's sick in a house out of that house so the other ones don't get sick things like that can make a really big difference in the community and to minimize the spread to others and really prevent other people from getting sick very quickly. So thank you for asking that. Those are the top things that come to my mind.
Andy, this is Doug again. I'm sure we could keep you online all day long asking questions, and you have really answered a lot of questions in my mind. I want to thank you very much. But I know you're busy and you've got other places to be, so thank you very much for coming, and good luck, and thank you for all the service that you're giving our state.
Thank you guys so much for all the service that you guys are doing. I really appreciate it, and always happy to come back. Take care.
If you
All
could
right,
please
thank you.
give the host back to Doug, perhaps, or to me, one of the other
Yes.
before you sign off. Thank you.
Do that. No problem. Here we go.